Welcome to the Pivotal Podcast. Today, we're joined by Dr. Adrian Gonzales, founder and CEO of Atomic Healthcare Solutions. In this episode, we'll explore Adrian's career journey, his contributions to pharmacy and healthcare, his role in leading healthcare teams, and his insights into the evolving landscape of healthcare and pharmacy technology. Adrian, thank you so much for being here with me today.
Hey, Ben, thank you. Appreciate it. This is an honor, and I'm humbled by this opportunity and excited to be here.
Yeah, absolutely. I always love to start these conversations just like back at the beginning. So tell me, what initially drew you to pharmacy, and then how did your career evolve? Because I feel like it's taken some very unique turns.
Yeah, no, definitely. Man, where did it start? Yeah, I always start in high school, honestly. I actually was going to be either a physician or an architect. And I had a really good high school counselor kind of mentoring me and just trying to really invest it in my future. And he just asked me different questions. And we kind of kept going back to people and taking care of people. Not that you can't take care of people as an architect, but we're going through this really like a personality test. And it was healthcare. And I was like, you're right. Like I want to do healthcare. So we started doing applications senior year. And then he kind of threw me a curveball at the end. He was like, hey, have you heard of, think about being a pharmacist? And he just told me about UOP. And at the time there was a collaborative between a couple other medical schools. And he's like, you can have a dual doctorate, pharmacy, PharmD, MD in the same amount of time. And you could technically, work as a pharmacist during medical school, where if you got your bio degree, it'd be difficult. I grew up on a farm. Money was important for me, how to pay for my own college. So he was thinking about this plan. I was like, I think that's great. Like, yeah, tell me more. So I did a last ditch effort into pharmacy school, and I think the rest is history. I did it. And then in pharmacy school, I ended up just enjoying it. I loved pharmacy, clinical pharmacy. And I was like, I don't think I want to go to medical school. I think this is it. So ended up pursuing a residency, become a clinical pharmacist in a hospital, got matched at my local town at an academic level 2 trauma center, in the midst of medical residents, nursing residents, pharmacy residents. So it was a great learning opportunity. I think, but it was at that point where, looking back, there were hints of, hey, you're not going to be a clinical pharmacist for long. You're going to go into leadership, because the director of pharmacy at that time ended up mentoring me, and she kind of gave me a lot of admin type of projects, root cause analysis for med events, sentinel events, compliance items. And I had a lot of great time there in the clinic doing ambulatory care, but one thing led to another, and that really kind of positioned me to take on my next role at, next company at Adventist Health, became a clinical manager, opened up the NICU. Their ask of me was, hey, we want a clinical program, get us out of the basement and get us, up on the floors. It's essentially replicate what you did at the county hospital. And I was like, that sounds exciting. And again, that goes back to me wanting to be a builder. And so in hindsight, it's like, I went to pharmacy school because I wanted to be a physician. I went into healthcare and leadership, and I get my architectural background in that because I'm building programs, I'm building infrastructure, I'm building people as well in leadership. You get to invest into people. And for me, I'm in a position where it's best of all worlds. But, my story kind of went into that role, ended up becoming clinical manager, created clinical programs, became the director of pharmacy. I really never sought to be a leader. It just kind of was either voluntold or kind of just naturally happened. Became a system regional director, and then ended up becoming the chief pharmacy officer or pharmacy executive there at Adventist Health, overseeing close to 30 hospitals, 400 clinics, retail pharmacies, infusion centers. And that's kind of where we really transformed what does pharmacy look like, and really looking at, one of my first projects was to create a telepharmacy program, and really what does clinical pharmacy look like. And so I was able, and then the other items were, we have one instance of our EHR, which, is Cerner at the time, but all 23 hospitals or 25 hospitals, we have kind of technically built them differently. And so when I'm looking at standardizations, and I was kind of doing all this work, I'm like, okay, we we have a lot of work to do on the EHR because I can't have a telepharmacy program without standardizations. We can't have a clinical program without standardizations. So I went all in on just creating SOPs, and that taught me a lot around brand standardizations, infrastructure, IT, collaborations. And with that journey being said, one thing led to another, and then I am where I'm at now. And like, I enjoy consulting. In what I do is I look for solutions. So whether it was when I was my time as a clinical manager, my time as an executive for IDN, and even now, people are just looking for answers, looking for help. And I think my heart is really to help, to create solutions, innovate. And really, as I saw the bridge between technology and innovation and putting it in the hands of a clinician, the end results of patient care were just astronomical. So as a consultant, I'm now helping not only health systems, but I'm also helping innovators create the next big thing related to better automated dispensing cabinets, better technology in the home, better, what does technology look like, data. A lot of times, so right now I'm just enjoying life, and that's kind of my journey of how I grew up from a farm. Literally, I learned how to drive a tractor before I learned how to ride a bike, and now taking care of a number of clients nationwide now. Never thought I'd be traveling the world, going to global headquarters for new innovations. And I'm like, yeah, like, let's do it. This is going to make all of our communities better. Why not?
Yeah, absolutely. So tell me more specifically about what you're working on at Atomic Healthcare Solutions. And then I would love to hear about the story of what spurred that.
Yeah, man, a lot of the stories honestly come from a story. So I actually just did a post the other day on just Father's Day, what it means to be a father. And one of the things I enjoy is storytelling. And some of the greatest leaders that I look up to are great storytellers, and because they connect. And so it's one thing that I'm able to inspire the team around me, inspire, essentially a change, a movement. And so one of the things that I constantly, even my days as a resident doing those RCAs, it was a med event, as a new pharmacist, we did the white coat ceremony, we took the Hippocratic Oath, do no harm. And you come to realize first month as a pharmacist or as a resident, wait a minute, we're actually harming people here in the hospital. And so that really opened up my eyes, and that, okay, I know what this oath is all about. And so that created stories, that created essentially a passion. It's like, I want to do no harm. Not only do I want to do no harm, I want to heal. I want to do better. And so then understand what a root cause look like, a root cause analysis. And so I think from that perspective, as I go into health systems now, is essentially doing a gap analysis, a workflow assessment, and really understanding, listening to the other side, the clinician, the administrator, the patient, and really understanding what's going on, where are the struggles at. But then as you kind of take a step back, you're like, okay, here's some operational inefficiencies, here's some safety items, here's a financial opportunity, here's an opportunity to raise the profession and really get create career ladders. And so I think one of the stories that comes to mind, two stories. One very personal to me. My wife ended up having a stroke 2 years ago. She healthy, 36-year-old, no medical history. She's healthier than I am. Not to say I'm healthy, but it came out of nowhere. So one of the things, you quickly become a pharmacist, you quickly become a healthcare executive, and you immediately become a husband. When your wife is there at the bedside and you don't know what to do, I literally, there's like, what are we doing? And then the clinician mode goes on. I was like, well, wait a minute. They ordered the medication, time is brain. And I'm just time is just slowing down. Luckily it wasn't my health system. It was a different organization. And but I knew the leader there. I was like, hey, like, my wife is here in the ER. Can you please help me understand what's, where's your order at in the queue? And literally it just took forever. And, she got the medication, she's all better now. Thank God, she's recovered. But that inspired me to say, well, what is my organization's data around turnaround time for TPA, for turnaround time for these critical medications, severe sepsis? I looked at the data and I was like, okay, if I want these medications to be prescribed efficiently, verified efficiently, administered correctly, what does that look like? And so I was essentially, I had to look into the data. The data didn't exist. So we ended up creating the data tables, the data visualization to say, what's my baseline? And we weren't where we needed to be. And, my goal was I want the physician to make it easy for them to put in the order. So they're essentially the order guidelines are set. I want it where the pharmacist is able to verify those orders efficiently and accurately and really focus on the patient, not necessarily, is this label going to print at the right printer? Did this item mismatch on the CDM? Or the order comments per T, and they miss out on all the clinical opportunity. And so I realized that as I was looking at going site to site and even talking to this organization that I was at in retrospect, she was like, our queue doesn't filter by type of drugs. It doesn't filter by the ER, Adrian. And I was like, how can we do that in the EHR? And we ended up doing it at their health system. I ended up doing it in my health system that I was at the time. And those are some of the things like, how do we, that patient, it's in that MRN, there's a patient, that's a wife, that's a husband, that's someone's family member. And that was my family member. So that really drove some of the changes that we did at the organizations that I've been at is there's someone there that we got to take care of. So what does the data look like? What are the roadblocks and make it happen? Another story that we talked about in the past was around, again, site visits. Did some discussions at one of our local clinics, and just shooting the breeze. How are things going? Just really trying to understand what can pharmacy do out in the outpatient arena, and kept getting story after story about access of drugs and essentially delays in care. And I was actually in the Central Valley visiting one of these clinics. And the patient was breaking down, and just like it took them about 6 weeks to get drug in hand. So I took a step back and I was like, wait a minute, our branding, our reputation, you come to our clinic, you get this diagnosis, and some of our patients aren't getting treated or therapy for 4 to 6 weeks. I was like, no, we got to do better than that. So again, breaking down that root cause analysis, what is it operationally? What is it on the technology side? What's the people perspective? What's going on? So really breaking it down. And then it really hit home. Again, I go to visit my family because I was doing the road show, visiting pharmacies and hospitals and clinics. And I see this specialty medication on my mom's kitchen counter. She's, that's what families, moms do. They always try to feed their sons. I'm like, I'm full. But as I'm eating and we're having she had this conversation, I see something in the corner of my eye. It's this specialty medication for diabetes. I was like, hey, Mom, like, when did you start on that medication? And she just turns red and she's about getting teary-eyed. And she's like, it took me 90 days to get this medication. I was like, what? I was like, and she just told me about the prior authorization. She ran out of samples. She told me about her A1C went from 7.6 to 9.4. And she was just, in tears, like, yeah, I literally just got it like a couple of days ago, but I have it now. I'm like, I'm a pharmacist. Why didn't you come to me first? She's like, oh, Miko, I don't want to bother you. I was like, no. It's like, and I just told her, like, hey, like, your story is the same story I'm hearing at these other clinics. And I was like, Mom, tell me more about what's going on. And then my dad jumps in. He's like, well, you haven't even told him how much we paid for the copay. And I was like, there's more to the story? And then she's like, well, my copay was $1,200 a month. And I was like, oh my God. And I'm like, it took you almost 3 months to get the drug. Now you're paying $1,200 a month for this med. And he's like, well, she doesn't take it every day. We're going to take it every other day. I'm like, you sound like just like Mrs., this other patient at the clinic that they told me the same exact story. And so I go back to these other clinics. I'm like, hey, let's get the data again. Turnaround time. What's the issue? We learned those prior authorizations where it was a delay. We learned that routing the prescription to these different pharmacies was causing delays. Lo and behold, we talked to the physicians, talked to the office managers, talked to the pharmacy. We create a solution, and we're able to cut drug in hand from 6 weeks to 3 business days. Prior authorizations went down from 3 weeks to 16 hours was our average turnaround time. Patients were essentially being cared for. And it was just because asking questions, having intentional leadership rounds, connecting all the players, looking at the EHR. How do we create a work stream to make it work for everybody Physicians were happy because that was one less thing they have to do on prior authorizations and calling back pharmacies. I think that the kicker on top of this is we improved brand, we improved patient care, we improved patient access. But part of the workflow that we created was, a lot of times in healthcare, with as it is today, margins are very slim. And so when we're creating quality focused programs, patient centric programs, like how do we fund this? How do we make it sure it's sustainable, where it's not just on, we're not living on mission alone, but we have margins to support the mission. And so very strategic and intentional is like, okay, we're going to route these medications to our own IDN pharmacies. We're going to make sure that they qualify for whether it's 340B, patient assistant programs, whatever it takes. And so we're able to route those prescriptions internally, therefore able to collect the margins instead of them going to a retail pharmacy down the street, Walgreens, Costco, those stores, but they came to ours. So we're able to not only take care of our patients in the clinics, we're able to take care of those patients as a transition of care. I was able to provide those medications, via mail order. And that's really what made the difference of that short turnaround time. And we went from being in the red year over year with our retail pharmacy program to being in the black. We went from single digit EBITDA to double digit EBITDA. The last 2 years that we're there, about $25 million in EBITDA margins. And I think this year they're closer to 40 to $50 million. And it's continued to grow. And this is exactly some of the programs that we're doing at some of the other clients that we're working with is like, how do we get pharmacy involved? I think CDC has 1 in every 2 patients is going to be impacted this month or is going to have a prescription. That's 50% of the population, whether pediatric or adults. When you look at health systems, I don't know how many prescriptions or how many orders or how many times a patient comes to the IDN without a medication order somehow. Pharmacy is involved. And so really getting pharmacy off the bench into the game of taking care of patients and going from the basement to the floors to the clinics and saying, this is what we could do and be part of the care team. And this is how we could help. And so that's really some of the work that we've been doing recently. And it's just been very, very fun, very rewarding. And I tell my mom every day, I was like, look, you help not only, her story was even better in that her copay ended up being, I think $20 was her copay from $1,200. Same stories. I had a patient and a family member on it. This is the last thing I'll say on this, but a life was transformed. I remember this family the clinic actually sent me a picture of this family saying, Dr. Gonzales, thank you for visiting us today. What you did just changed our life. Our A1Cs were controlled. Part of telepharmacy program was also to get a telepharmacist to help manage their diabetes with their primary care physician, with access of care, with affordability. But they sent me this picture of them next to their pickup truck. And I responded back like, hey, I love the story. Thank you for telling me. It really means a lot. But you obviously shared this picture of the pickup truck. What's the story behind it? I'm calling them. And they're like, you don't know what you did to us, because we ended up selling our second vehicle. Our grandson lives with us. We couldn't afford it, the medications. So we ended up selling our second vehicle. We've been carpooling not only to work, but also taking our grandson to high school. This is our pickup truck. We have our life back. You not only took care of us from a health perspective, but you've given us our quality of life back. And we have, you and the organization just to thank. And we want to share that, not only is our A1Cs that goal, but this is, we can't thank you enough. And I'm like, that's why we're doing this. Is we're changing lives, whether it's health, wellness, access, quality of life. We're really looking at it from a whole patient care focus, from the social, economic, and their overall well-being. We got to look at it from its entirety. And that's just one of the stories that we've had. And like, how do we grow this? Well, how can we do this in other health systems and other communities?
And so with that one, they were able to get the truck back, to rebuy the truck, because the copay dropped so drastically from your services.
Exactly. He actually got an upgrade. He told me they got a new pickup truck, a brand new one. He's like, I had to trade in the old one, but we got a newer one, even better once I can afford it now. I'm like, hey, good for you. He just brought a good smile to your face. And it's just like, man. So I ended up calling the pharmacist, like, hey, you remember patient so-and-so? They want to say superb, clinical for handling their diabetes. Thank you for taking care of them from the patient assistance program, getting their copay down to getting the prior authorization done. Again, you got to celebrate those wins. Let the team know what you do matters. That those phone calls, those interactions, those monitoring those labs, being intentional, that discretionary effort. And I said, this is why we do what we do. And I was like, whether you're the CFO and what makes you happy is the $1 million in the bank, whether it's the patient experience executive and you like these stories, philanthropy, whatever it is, like what we do matters. And so really preaching that to our pharmacists and technicians and just really celebrating them. So then it inspires them like, hey, I want to do this again. Where else can we do it? So it just created this movement. And that's really, what we're about is just, thinking things simply. And that's our trademark is, simple solutions, atomic results, is because it's not rocket science to really get everyone involved. How do we create simple, sustainable processes, looking at people, process, and technology optimization, creating a culture that allows for ongoing performance improvement to really get these results that we're all looking for. And it has to be a package deal. And that's really what we kind of look at is it's a complete package when we do an assessment, because when everyone wins, everyone wins, when it's a win-win relationship, whether it's patient, businesses, IDNs, payer groups. And so we're really looking to make sure that all of our encounters are win-win relationships.
Yeah, absolutely. And I don't want to gloss over this because they're so impactful, but literally prior authorizations went from 3 weeks to 16 hours. Drug in hand, 6 weeks to 3 business days. Copays in some instances over $1,000 to $50 or even free, right?
Yeah.
Like, so, and what was it? What's the thing that you guys are doing that's achieving such astounding results?
Yeah, so part of the discovery, I could go in so many different rabbit holes, but some of the operational perspectives is we realized that the prior authorizations weren't being completed either because they got lost in faxes. They were getting faxed to the retail pharmacies. They would get to it when they would get to it. They would then communicate back to the office on either a phantom fax machine, an inbox that no one looked at. And so that just compounded the delays. And then when we were looking at some of the root causes of the denials, it was like, well, why was this denied? We look at the coding, we look at the progress notes. It's like, okay, we didn't clearly put the right diagnosis, the right codes in place. That's why it's getting denied. So working with our physicians, working with our nurses, working with our EHR team, and making sure that everything was just very streamlined for the specialty providers, creating a formula that worked for them, the order sets that worked for them. And then we introduced essentially pharmacy into that work stream where it was a physician, nurse, and MA and patient. We introduced the pharmacist, the pharmacy team. So we had a clinical pharmacist to essentially be an extender of the physician to essentially help them on the clinical side and also help with some of the verbiage around the PAs. But then we also introduced the concept of a pharmacy technician navigator that really said, hey, those PAs, all that paperwork, that the to and fro, I'm going to take the physicians and the nurses out of it so you guys can focus on patient care. I will own the pharmacy piece. I'll talk to the pharmacy, to pharmacy speak and make sure the payers understand what we're needing. That fast track things. And so we're like, oh my gosh, we're getting results. But then the next cogwheel in that is like, well, we did our part. Why is there a delay to get that prescription from the traditional retail store to the patient? And that's what we realized, like, what if we bring this in-house? So it was like, we could do this better. And so we ended up talking to the patient, like, hey, would you mind if we filled your prescription instead of the one, in your local community? We're like, yeah, if you're able to get it quicker, it's like, we'll get it quicker and we're going to guarantee that your copay won't be more, but we're going to look to see if we get it for less. And lo and behold, we were able to do that work. And that's really where we got the financial benefit. We were able to get that reduced turnaround time of drug in hand from 6 weeks to 4 weeks to 3 weeks to 2 weeks to 3 days. And that's really when we put the pharmacy team in that workflow and really made sure that they're integrated is where we got those results. And
and so
I'm excited.
Yeah, and so not even that. So shorter timelines, less expensive for the patient, but more revenue for the healthcare facility too, right?
Exactly. You created a program that's now self-funded. You created an experience for pharmacists and technicians to have a new way of practicing pharmacy that gets them excited. you create this revenue stream to expand access of care. A lot of these institutions that I work with are either critical access, 340B, academic centers or non-academic centers. When we're able to go from the red to single digit, right now healthcare, I just was reading Kaufman and Hall, they have this, where are we at in healthcare for June? 40% of healthcare organizations are now making or are profitable, but the other 60% are not. What's the difference? So when you dissect it, we're looking at cost of goods, revenue cycle. Are we collecting? What does that look like? And so we're still not out of the woods from a financial perspective, and operating on single digit margins, single digit EBITDA isn't sustainable. So anything that we could do to create value, to improve our branding, but then also hit our bottom line to expand the mission of that organization, that's really the winning recipe of really creating sustainability. And that's really what we're looking for.
Yeah, absolutely. So for anybody listening who doesn't know, tell me a little more about what you mean by 340B.
Yeah, so 340B is actually a government program for drug purchasing. It's essentially, it's a qualifier for certain hospitals. So essentially, if you take care of patients that are underserved, essentially a disproportionate share hospital. And so there's different qualifiers. And so we're able to get these medications at 340B pricing. Traditionally, they're for hospital-based organizations or hospital-based clinics, outpatient departments. So typically we see this in the infusion centers, hospital-based infusion centers, hospital-based clinics. And so from a 340B perspective, healthcare organizations are able to purchase these medications at a reduced rate. So what a drug might be traditionally maybe $1,000, hospitals are able to buy them at $1 or $10. So when we're able to bill, the margin dramatically increases. And the whole premise of the 340B program is to make sure healthcare is affordable in these low economic areas. How can we ensure that there's access? And because all these organizations are nonprofit that are 340B, all that money is invested back into the organization to expand care. And so that's the premise behind it. But part of the situation in 340B landscape is there's been a lot of changes from a legislature perspective. How can we, pharmaceutical companies are like, well, how can we ensure that hospitals are using the 340B drugs and dollars for the right reasons? How can we make sure XYZ is occurring without there being diversion? Or essentially, one bad hospital sometimes ruins it for the majority. And so there's a lot of rules in place to make sure that there's compliance. But as a health system, a lot of the landscape has changed in that hospitals are now acquiring physician offices or acquiring medical offices that may or may not be on the hospital license. But because it's an IDN, there's different ways, different processes that we could create that would make typically a patient that's not 340B or a prescription that's not 340B, we can make it 340B eligible with some of these workflows that we've created to really take advantage of the program, but really give back to the community. And so that was the heart of the program is, improve the margins on pharmaceuticals to really expand access, make healthcare affordable, making sure that patients are on the right medications, not the less expensive one that may not be the best one for them. And so the program, when it's used and leveraged effectively, really we're able to take advantage of what at the spirit of 340B we're able to do. But it requires some innovation, requires really creating a pharmacist that is a pharmacy encounter that's on the EHR, that is in a 340B eligible virtual clinic, is what is an example of one that's on the Medicare cost report. We just made it eligible. There's other things that we could do, but those are some of the things that is available to us that sometimes people are just like, well, I'd rather do it the easy way. But nothing in life that's easy is either sustainable or lasts. And so we have to really roll up your sleeves. Well, how do we create a sustainable process that takes care of the patients, that's compliant, and it takes care of the organization? So we create the sustainability, and that's kind of what we've been doing in some of these health systems that we've been helping.
Yeah. And you mentioned the EHR. What's the role of informatics in all of this?
Wow, so much. Here's another story. Again, you go into these clinics or these different hospitals thinking that you're going to help in one area, and then another opportunity opens up. So I went to this one clinic really focused on growing operations, creating some financial incentives. And lo and behold, it's like it follows me. Another med event occurs. And I was like, okay, what happened here? And so essentially, this was a specialty clinic, but they were able to order medications for a different specialty. They went from methotrexate, ordered methylprednisolone. We ended up uncovering some other things, and even vaccine errors. We're like, okay, they only have 3 vaccines on their shelf. Why do they have a laundry list of 300 vaccine availability? So there's a compliance issue, there's a safety issue. And so when we look at the informatics and the EHR, we're like, let's create a formulary that's clinic or specialty location or specialty specific. Let's create some guardrails to say, okay, if you're a pediatric physician, let's make sure that your formulary is pediatric driven. Now there might be, but you have the option to get maybe some adult medications or some adult dosing for these larger kiddos, sure, but it requires an extra step where there's an alert built in versus a free for all. Informatics is so critical in efficiencies from a medication safety perspective that we're just talking about now. And then one of the other things that we realize is so many of our denials we've seen. And so when you look at revenue cycle, there's 4 big buckets. There's there's access. There's the mid cycle. So essentially from access, what does scheduling look like? Are we doing prior authorizations ahead of time? We look at the mid cycle of the rev cycle. So I call it mid cycle, but that's really the build. Did our informatics team build the EHR, that product, that orderable with the right CDM, the right NDC, the right billable unit, the right unit of measure that we get reimbursed? I end up getting a UB40 with their the revenue, their invoice. I was like, we got exactly 10% of what was expected based off of our contracting, and I was like, we ended up doing that root cause analysis again. I was like, it's our billable unit. We're only charging for 1 billable unit every time we dispense this 1 vial. This 1 vial it should be billed in increments of 10. Therefore, we're getting 10%. So we were expecting close to $100,000. This was an oncology medication, a really specialized medication. We're expecting, again, we're looking at different contracts and payers. We're looking at a 6-digit invoice, and I was only getting maybe about $10,000 worth. And our coders are like, oh, we got something better than nothing. I was like, wait a minute. No. Then I was like, okay, we got to fix the billable unit. Then I get another example of, hey, we're getting all these denials. And I'm like, well, can you give me one? And then I look at it, it's like, okay, NDC, the NDC failed. So then when you look at the NDC, I was like, oh, the last digit of this entry is wrong. It should be a 1, not a 2. We resubmit it and we get paid. And they're like, how many years have we gone through with all these denials? So that's one of the metrics that we've been looking at is like, okay, is it an access issue? Is it a mid-cycle issue? Is it a documentation issue? Are the nurses or physicians putting in the right documentation? The start times, the end times. And then at the end, we're looking at those, the invoices to make sure that we're collecting correctly or the contracts are adequate. But from an EHR informatics perspective, they're everywhere. Is it easy to schedule? Are we building these correctly? What does that audit look like? A lot of our drugs have a new price schedule every quarter. How often are we updating the price schedule? If we're lucky, we're doing it annually. If you're good, you're probably doing it every 6 months. And I'm like, hey, you're doing great. You wouldn't believe how many hospitals and organizations, they build their EHR. They get Epic, they get Cerner, they get whoever. They build it one time and they never look back. And I'm like, hey, this medication has changed pricing, I don't know how many times, or this drug is no longer on the market. You're trying to bill for something that isn't going to get reimbursed. It's an automatic denial. We got to put in the new NDC. So
what is an NDC again?
Essentially, every drug has a code. So essentially, like for example, like with food, with that barcode, there's like a 9-digit number or 11-digit number. So every drug has an NDC or has a code that says these corresponding numbers represent the drug, the manufacturer, and the package size. So it's actually the National Drug Code is what it stands for. And so every single drug has its own code. And so if I want to look at Tylenol that is made by, I'll make up a different name, Mylan brand, it has its own unique number. If I look at Motrin that's made by this other company, it has its own number. And so if I'm billing for that, I'm going to get reimbursed for that specific item. And so it becomes very important from our data tables, from our order sets, or from our build, that the drug that we are prescribing is the drug that's being matched behind the scenes. And then when we're doing scanning and BCMA, one of the biggest pitfalls of BCMA is if we're not keeping up with that barcode for each of the pills. Again, requires ongoing quality assurance to make sure that the new products coming in are going to scan, because if it's not in place, they can't scan, likelihood of an error occurring. But if they're not scanning, they're not able to document on the EHR. Therefore, they're not going to get a collection on that bill unless they're doing some sort of manual billing on the back end, saying, "Oh, I did give that Tylenol, I did give that XYZ drug. I'll just do it manually." You talk about inefficiencies from a labor perspective. We talk about not optimizing or leveraging technology the way it was intended. We're sacrificing safety. You're sacrificing, essentially, you're leaving dollars that are yours on the table, and that's one of the reasons that I believe that healthcare right now is that separates what Kaufman Hall's publication this last week of those that are actually profitable and those that are not. I think a lot of it comes related to pharmacy, and a lot of it is related to that revenue cycle. Are we collecting? And are we collecting our entire bill versus just partial?
Wow. It sounds like so much of it comes down to almost having too many options. Like you talk about those guardrails, and it's like, hey, let's only have in our system right now what we're actually offering, like in our setting, our physical setting, right? And then let's make sure that our codes for that are in alignment with the codes that the payer uses, so that we can make sure we're actually going to get approval and getting reimbursed. So it sounds like the gap in the system previously is that when something was submitted, if it's just denied, it's like, okay, I guess we're not getting paid on this one. Instead of like a hold on, it's not just that they're denying it for no reason. We gave a drug that was approved, and we should be due payment on that. So where was the gap coming from before? Was it just like, we've got so much going on, we don't have time to go back and revisit that? Or like, what's the root cause, I guess, of this problem?
Yeah, no, I think that's kind of why when we look at in a leadership role, the basics, PPT, right? People, process, technology. I think the other key ingredient is culture and behaviors. Why was it okay for all those write-offs? Why was it okay for that clinician to say, it's good enough, or I'm not going to raise the flag on it? So we have to address the behaviors or the culture of an organization as well as we evaluate the process, as we evaluate the technology. Part of the root cause of some of this was, one, bandwidth. There is actually in a lot of our EHR or revenue cycle teams, there's reports that people could run and create, why did the denial happen? And then you're able to use that report to do a crosswalk to say, okay, it's the price schedule, or it's an NDC is inappropriate. So, talking about education and educating our staff, a lot of times, technology creates efficiencies. And so then the next question is, well, what are you going to do with that new time that clinicians have or frontline staff have? We have to be thinking about, how do we repurpose those hours? And instead of, cutting those costs, well, we don't need them from operations. Like, well, wait a minute. The technology actually introduces another workflow that we have to staff. We need to repurpose a portion of that to do this new work from a quality assurances to make sure that we are collecting, that the technology is working as intended, that we're doing a deep dive to make sure that we're continuing to automate, we're continuing to get efficiencies, so we could get that full ROI versus, hey, we implement the technology, but we're not going to, it's like getting a sports car, but only drive it in first gear. And it's like, wait a minute, we invested in all this technology. We need to really optimize it. And optimization isn't just at implementation, it's ongoing optimization. And that's what we talk about, that quality assurance performance improvement, and having that culture one of our current projects is introducing high reliability organization philosophies, or in just culture and a safety culture. So when we're looking at the technology that was installed, this current client this past summer, they're great. Like, yeah, it's been great. It's like, well, so when was the last time that we evaluated that the technology is working the way it was intended? It's like, well, we haven't. It was 9 months ago. I was like, okay. As we're doing the evaluation, the technician ended up showing me that they had a picking error. And I was like, hey, before we proceed, you caught yourself, great, but let's understand, why did you make that mistake to begin with? And when we look at it, it's like you had two bins in the carousel side by side. They're both liquid dose cups, and her hand literally just migrated 1 inch, and she went to the wrong bin. Even though the machine said was glowing, saying this is the bin to pick from, her hand migrated just a little bit, and she picked the wrong unit dose cup. We took a timeout, and we're like, okay, why not move these bins these drugs that look alike? Let's separate them a bit. And that's what we end up doing from a safety perspective. But we do the same thing from a revenue cycle perspective, from a clinical perspective. Evidence-based medicine is evolving. So if you expect CPOE to have these power plans that were built off of last guidelines, what are we doing to put in the new guidelines for severe sepsis, the new guidelines to treat stroke? Or how are we maintaining evidence-based medicine within our EHR? Because, one of my, it's not a favorite story, but it's one of the things that I grow passionate about is I find in so many pharmacies little black books that have all the cheat sheets of these are all the things that we have to fix before we process the order. Things like, don't let, the EHR will default the printer to go to this printer, but we got to change it. It defaults to this old NDC, but we got to manually change it to this new NDC. Order comments are missing, or we got to type in notes for the nurse not to do this. I'm like, has anyone just put in a ticket to just automatically change the default? It's like, you know what? We haven't. And it's like, how do we create a culture of challenging status quo, to have a questioning attitude? And so that's why I always say people, process, and technology 100%, but it's also about behaviors, making sure it's easy to do the right thing. It's hard or nearly impossible to do the wrong thing. And technology, ISMP has some great articles around, human, human safety initiatives versus system initiatives that are essentially leveraging technology or processes that make it, barcode. BCMA is a great example. Interoperability with the EHR and the drug infusion pumps. I was helping a hospital about a year or 2 years ago with interoperability, and they're like, it's not working. Why? And we're looking at the physician's orders was ordering mLs per hour. The pump is in microgram per kilogram per hour. There's a mismatch. I was like, well, we have to change the EHR or the pump. One has to change. And then you look at, the guidelines. It's like, and now that one's also different. It's like, we have to reconcile all this. So our build, it matches our workflow, and the technology supports all of it versus everything competing against each other. So it really takes, informatics and this huge appreciation of technology, in that technology is only as good as it's implemented and optimized. You have to have the process, you have to have the education and training behind it, because just because you buy the latest and greatest robotic, if you don't implement it, you're not going to get the results that you're looking for.
Wow. Yeah, that's so many things to consider right there, right? And it almost seems like what it takes is somebody to come in, and maybe it doesn't have to be an external thing. It just has to be time set aside to audit the systems and processes, right? To make sure that everything is in alignment.
Yeah, essentially, yeah, a quality program within technology operations, technology implementation. We have to insert some sort of quality assurance programs. So whether it's retrospective, whether it's, I think the days are over where, I'm very proud of all the root causes that we've done. An event occurred, let's fix it so it never happens again. That just is foundational. But I think we need to start thinking about where and when is the next error going to occur, and why? How can I get in front of it via a better process, a better technology, so that it doesn't even happen? So you're looking at near miss reports, you're looking at just your entire ecosystem in your environment of, you know what, this, the data is telling me that this is a lot of your miss. We're getting lucky. Well, let's fix it. And then getting a step ahead of that, saying, this is where we're most vulnerable, or this is where we're lacking technology. What are we going to do to ensure that we have those processing technology to prevent the errors from ever happening again, versus waiting for that event to occur, then doing the RCA, then changing things? We have to be ahead of things. I think that's kind of where, as the new technology is coming around, which is great, around artificial intelligence, around some of the software that's happening, some of the hardware technology that's making it easier for the clinician to pick the right medication, to scan the right medication. Again, the technology is only as good as the user and the behaviors that they're using that technology. Everyone's implementing BCMA, which is great, but if you already gave the drug after you do the BCMA process, you just defeated the whole initiative. I'm probably speaking to the choir, but some of our viewers are probably like, yeah, that's our nurses. Unfortunately, sometimes they just get in a rush. It's like, well, let's take a step back. Why are they in a rush? Why is it taking 20 different clicks to process an order where it should only take 1 or 2 clicks? And that, when I talk about that black book that pharmacists have, I was like, why is it taking so long to process a simple Tylenol order at this one hospital, but their sister facility across the street, it's streamlined? What's the difference? And so that's kind of that mismatch of using data, having a quality program, having the informatics team looking at that saying, oh, let's fix it. Because the more, as we all know, the more manual steps there are, the more likely there is to be a med event. We're going to have, when we talk about the revenue being missed, increase in time, it's just very inefficient and unsafe. And so by that means, yeah, I think there needs to be an investment in this space.
Wow. So in the next couple of minutes that we have left, if we think about like the next 1 to 3 years, maybe, what have you seen that you're most excited about in terms of something that's got real potential to positively impact patient outcomes?
Yeah, no, I was privileged and blessed to be part of a hospital at home program, and really, during the pandemic, if one thing came out of the pandemic, there's a number of things that we've learned from the pandemic, but I think one of those things is we learned that certain disease states can be treated in the home. And I think as we look at transitions of care, as we optimize the hospital, as we start treating patients in the outpatient setting in the clinics, we also have to start thinking about the home environment. What does the home look like from an automation perspective? What does that look like from a pharmacy perspective? We talk about Bird and Uber, and essentially getting to that last mile between the consumer and that vendor. So in healthcare, what does that last mile look like, and how do we insert ourselves in the home? So I'm most excited about pharmacists entering the home with some sort of medication management technology that we're able to prevent medication errors, that we're able to ensure that from a compliance perspective, CDC has published a number of data that 7 in 10 readmissions is related to some sort of medication. So either they didn't take it correctly, they couldn't afford to take it, they're taking, maybe they're not their drug, maybe they're family members, or they're self-diagnosing, self-medicating. A lot of these readmissions are occurring because of a medication. So what are we doing about the home environment to ensure adherence, safety is happening? And we talk about technology in the traditional health system space. Well, what does technology look like in the home? And I'm excited to be part of some of these discussions and say, let's take care of mom and dad and grandpa and grandma in the home. So I know they're taking their meds. I know they're taking it safely as prescribed. And I think that's some of the next things I see in the next couple of years really evolving, is this whole concept of home care, and really getting pharmacy out there and really collaborating with all the clinical teams.
Yeah, that's amazing. Wow, Adrian, I really appreciate you taking the time to go through all this with me today. If any of our listeners are curious to see, to follow along with what you're up to at Atomic Healthcare Solutions, is there some place online that they could find you and find out more information?
Yeah, I would love for them maybe just check me out on LinkedIn, Atomic Healthcare Solutions, or you could look me up on LinkedIn or our website, www.atomichealthcaresolutions.com.
Yeah, that's perfect. Well, thank you again for sharing your stories and the impacts, and you've just given us a lot to think about today, and I really appreciate it.
Yeah, no, thank you, Ben. Appreciate it. And it takes a team. And it's not one person or one department. It takes a village, and I'm just excited to be part of it.
Yeah, absolutely. To our listeners, we'd love to hear your thoughts and experiences on this episode. You can share your comments on LinkedIn or directly on the podcast website at pivotal.buzzsprout.com. And if you know someone in healthcare who would find this episode inspiring or beneficial, please share it with them directly. You can stay tuned for more episodes here on the Pivotal Podcast, where you can listen live on LinkedIn or anywhere you get your podcasts. Until next time.